Greetings. Let's start with arthritis and cover arthritis and some of the diseases in the next few videos. First thing, what is arthritis? Itis of the joints is arthritis. Okay. Uh, Arthralgia is algia, is pain of the joint. Okay. So that's first thing, and that's really important. And generally, the area that we study this in detail is rheumatology. And again, it is related to immune system. A lot of the diseases are within this area related to immune system. Again, it's inflammatory and immune mediated. A lot of this. There is no one blood test for the most part that gives you these diseases in there. Most of them are diseases where there's a pattern. So in other words, I got factor X, Y, Z, alpha, beta. You know what? I got this disease. Okay, so that's sort of where we are. Um, So we understand the difference between arthritis and arthralgia and what rheumatology is. Okay, let's look at a couple of things. Whenever we do arthrocentesis, what's arthrocentesis? I put a needle in the joint and I aspirate a joint fluid and I send it for analysis. Okay. And that's arthrocentesis. If you have somebody that comes in with one joint arthritis, inflamed joint, it's acute one joint inflamed joint, and it's undiagnosed, acute undiagnosed monoarticular arthritis. It's our test, it's our go-to test. Okay. Uh, the big thing with this one is it helps us differentiate, it helps us give us the diagnosis of septic joint, if there's infection in the joint, um, versus if it's an inflammatory disease. Okay, so if there is sepsis, the joint fluid is opaque or has pus, and it has greater than 50,000 white blood cells. If it's inflammatory, it's cloudy. It's got 2,000 to 50,000 WBCs. Additionally, it may have crystals. If there are crystals, we can actually use that to diagnose crystal disease. So if you see positive bifringent rhomboids, it's calcium pyrophosphate, and you got your diagnosis of CPPD. If you have negative bifringent needle-shaped crystals, you're able to see. Those are uric acid crystals, and you have a diagnosis of gout. And we'll talk about this in both these diseases in detail in a bit. Okay. So that's one. Next, ESR versus CRP. So a lot of these diseases, okay, uh, have inflammation, are associated with inflammation. And that inflammation could be in the joint, which you can see with uh, swelling, redness, heat, right? And then, of course, pain. So remember the cardinal signs of inflammation, okay? Or this inflammation could be in the body, and both. So again, if there's inflammation in the body, one can use tests such as our acute phase reactants or acute phase proteins that we've already talked about. We can actually draw somebody's blood, measure it, and they're going to be elevated. Two of them are ESR, erythrocyte sedimentation rate, and CRP, C-reactive protein. Okay, It measures the amount of inflammation. It is not specific. So in other words, if you have inflammation, it's going to be high. It's going to correlate with the amount of inflammation, but it doesn't tell you what's causing it. Okay. However, once you detect the cause and treat it, the inflammation will go down, and so will these blood tests. So you can use these blood tests to see how bad the inflammation is, and when you treat that disease, how much inflammation has gone down, and how have we targeted inflammation, and how's the disease process going. Okay, CRP is better because it rises and falls rapidly with inflammation, so it is more uh, it is more reflective of what's going on in the body immediately in terms of inflammation. So C-reactive protein is better than ESR. Next, let's talk a little bit about degenerative versus inflammatory. And we'll talk about it in just a second. One may have a joint that has worn out, or one may have an inflammatory condition which is causing the joint to be inflamed. Both of them are going to have pain. So the question is, how do you differentiate it? So again, inflammatory is going to have swelling, pain, redness, heat. Degenerative is not going to have redness and heat. So no redness and no heat. Okay. When you use a degenerative joint, it's more painful. And usually what happens is you wake up in the morning, the joint has had its rest, and it's okay. And then you use it through the day, and then the pain gets worse because you're using a degenerated joint. Okay? However, the inflammatory joint, the big complaint is stiffness. Okay? It's actually pain when you rest that joint. So they'll wake up in the morning with stiffness. Okay? And there's pain on rest, and it's when you move, the stiffness gets better, the pain gets better. Again, inflammation means CRP is going to be high. Okay, degenerative joint, CRP is not going to be high. Okay, so we're still studying some basic terms. Okay, and now the big thing is we know the difference between inflammatory versus degenerative disease. We know what rheumatology is. We know arthralgia versus arthritis. We know if there's inflammation, how can we measure it with some non-specific blood tests, and then how to uh, look at arthrocentesis, fluid that we derive from arthrocentesis, and figure out whether it's septic versus inflammatory, and even within inflammatory are there crystals. Okay? Okay, now that we've figured some basic things out with rheumatology, I'm going to give you the lay of the land first, and then we'll go talk about individual diseases. So whenever you have pain in the joint, it's arthralgia. However, if you have pain without signs and symptoms of inflammation, there's no redness and heat. There may be pain, no redness or heat. Okay, and a lot of times no swelling. You have arthralgia. Then the joint pain is arthritis, and we'll talk about that. Okay, that's osteoarthritis. Now, this is not a very good name because arthritis, by definition, would mean inflammatory. However, this is degenerative joint disease. There's no inflammation. It's just over a period of time, your cartilage in the joint has worn out. So CRP is going to be good. if you extract the joint fluid, it's not inflammatory and it's not septic. ESR CRP, as I told you, would be not negative. Before that, the patient is going to not complain of stiffness as much. They're going to complain of what? Hey, through the day, the pain gets worse with use, right? So that's osteoarthritis that we'll talk about in detail. Okay. Now, but this is the bread and butter. What if there's pain with signs and symptoms of inflammation like swelling, redness, heat? Okay. So there's several diseases within this. So the way to divide it is you say, okay, is this something acute? I was fine yesterday, and this morning this happened. That's acute. Or chronic. Okay, acute or chronic. That's question one. Chronic means it's been going on for a while, it comes, it goes. Okay, so that's one. Now, whenever you see acute, you can think of four things. An acute joint arthritis. Think of four things. You have trauma, infection, crystal disease, and fourth is reactive arthritis. Okay, once again, you think of acute arthritis and it usually happens in one joint. It was fine yesterday, I woke up with this morning. Trauma, infection, crystal diseases. So we'll talk about the two crystal diseases within this. And reactive arthritis. So that's four. Now, that's acute. Whenever they come in and they say, oh, I've been having inflammation in these joints, but it's gone on for a while and it's happened in more than one joint or multiple joints or polyarticular. Okay, now you're thinking of other pathologies such as psoriatic arthritis, ankylosing spondylitis. Okay, that's different set of pathologies. Okay, inflammatory bowel disease arthritis. Okay, lupus and rheumatoid arthritis. Okay, a little bit more. And rheumatoid arthritis. Now, Prashant, what about if they come in and they've had history of chronic arthritis, inflammation in the joints? Okay, however, they come in with suddenly one joint that's acutely inflammatory. Well, if that be the case, then it may be a flare. Okay, so if that may be the case, then it's a flare. Okay, then it's a flare of that disease. Okay, got it? So again, you have rheumatology. Within rheumatology, you may have pain. But if there's no signs and symptoms of inflammation, you got what? Osteoarthritis. We'll talk about that. If they come in with acute monoarticular arthritis, and there's no history of anything chronic, then you're thinking trauma, infection, crystal disease, and reactive arthritis. Okay? If it's something which is chronic and it's more than one joint, now you're thinking of psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, spondylitis, lupus, and rheumatoid arthritis. Okay, you guys got it? Now, in real life, again, becomes more complex. Patient may have one of those chronic diseases and may present with a flare-up of that chronic disease, and it may present as monoarticular arthritis. Okay, so that's how they overlap. For testing purposes, they're going to be more clear. Life, sometimes not. That's why you'd have a patient with lupus come in, and they've been using drugs, you know, IV drugs, and so now if they come in with arthritis, we might have to tap that joint to see whether there's an infection brewing or not, or is this lupus that's flaring up. But again, that's where all of this becomes very interesting. Now, a lot of these diseases, gout, infection, okay, rheumatoid arthritis, lupus, a lot of them have some or the other markers that support, not diagnose, but support the diagnosis. However, you have 4 that are seronegative. So in other words, there is no blood test for them. Okay, and they're called seronegative. It's in the name, spondyloarthropathy, diseases of the joints, okay, that are seronegative. And the way to remember it is pair. So remember pair P, psoriatic arthritis. So this is a chronic polyarticular arthritis. Ankylosing spondylitis, again, same. It is chronic polyarticular, and so is inflammatory bowel disease. Okay, the only exception to this is the reactive arthritis, the R. Okay, it's the only exception. So the reactive arthritis presents as acute monoarticular arthritis. Okay, so that's the lay of the land. Now we'll go exploring these diseases. Let's do a quick recap. We talked about what is rheumatology and how we're going to study inflammation of the joint and diseases of the joint. Okay, we talked about how for most of them there's no one test or blood test. It's a pattern recognition. Okay, we talked about how you can look and draw fluid from the joint, arthrocentesis. Again, the physician does that, and it helps us differentiate septic versus inflammatory arthritis. ESR-CRP, how we can track the amount of inflammation, even though it may not help us get to the source of the inflammation. We talked about degenerative versus inflammatory diseases. Again, the way we divide it, and this might help a little bit better, is we say, okay, rheumatology. If there's pain but no signs and symptoms of inflammation, then we have osteoarthritis or degenerative joint disease. And I don't like that name, and I shared with you why. But if it's arthritis, I say, is it acute or chronic? If it's acute and monoarticular, we're going to look at trauma, infection, crystal, or reactive arthritis. Again, if it's chronic, okay, and it's polyarticular, you're looking at psoriatic arthritis, ankylosing spondylitis, IBD, spondylitis, lupus, and rheumatoid arthritis. And then I gave you a subdivision of seronegative arthropathies, which is pair. Psoriatic arthritis, ankylosing spondylitis, IBD spondylitis, and reactive arthritis. And even though all 4 are in the same category, they are divided. Reactive arthritis is acute monoarticular arthritis, while the rest of them are Chronic polyarticular arthritis. Okay, now let's just talk a little bit about trauma and we'll get it out of the way. Okay, so when we look at trauma in your question or with your patient, there's going to be a very specific history of trauma. So again, trauma, we will try to cover it separately as an entity by itself. For all traumas, check airway, breathing, circulation, disability. That's for the whole body. Additionally, if there is an air injury, uh, then check the vascular and neuro status distal to the trauma site. How do you do it? Let's say I have trauma in my elbow, in my right elbow. I ask the patient, hey, wiggle your fingers, right fingers for me. And then I touch those right fingers and say, can you feel it? And if they can, yes, the neuro is good. And then I check and see if the vascular status is good. In other words, color. Is it pale or pink? Okay. Secondly, cap refill, capillary refill, less than 2 seconds. Pulses, can you feel them? If you can, you've got intact vascular and neural status distal to the trauma site. If it's compromised, emergency. Call a provider. Somebody needs to restore that blood supply pretty quickly or the tissues are going to die. That's true for whether a surgical procedure has happened, so it's trauma related to surgical procedure, or actually it's a trauma, which has happened out in the real world. Okay, so that's how some basics about rheumatology, how we divide diseases, and then last but not the least, trauma. So we'll go through the rest of the diseases as we move on.